Hello, I'm Lisa Russell. I'm the Supervising Health Physicist of the Inspection, Compliance, and Enforcement section of the Radiologic Health Branch, part of the California Department of Public Health. And I'm here today to talk with you about regulation of CT in California, and that was prompted by Senate Bill 1237. And we'll start with the mission of the Radiologic Health Branch. First slide. Mission of the Radiologic Health Branch is to protect public health and safety. And we do that by ensuring the safe use of radiological equipment and materials within industry, medicine, and research, by preventing radiological health hazards, and by educating our stakeholders and enforcing applicable state and federal regulations. Next slide. As you know, public awareness of CT use is much greater now than it was 10 or 20 years ago. People see CT advertisements, sensational news stories about hair loss and babies being overexposed, and they see it used in legitimate research and published in magazines. Then there are awareness campaigns such as the Image Wisely and Image Gently, industry news, and even our own outreach efforts have made people more aware. And people are legitimately concerned about radiation safety for themselves and for their family and their friends. Next slide, please. I want to cover a little bit of the background of 1237. It was concern over radiation safety that led to introducing this bill. But before that, California really had no reporting requirements for exposure events involving machine-generated radiation, and had no requirement for CT doses to be recorded or verified, and no accreditation requirements for anything other than mammography. Senate Bill 1237 was introduced in 2010, and it was amended in 2011, and then further amended by AB 510 in 2012, and that's the current version that we have now in place, and that's what we'll be going over. Next slide, please. We'll be looking first at Section 115111 that did become effective July 1st, 2012, and this requires recording the CT dose in both the patient record and the interpretive report. It requires annual displayed dose verification, at least until this July, unless the CT unit is accredited already. And that dose verification is for 3 protocols only: the standard adult head and abdomen, and the pediatric head. This section of the law also defines dose, and what dose means in this section is the CT, DI-vol, and DLP. Those are dose indices. They're not effective dose or skin dose. And whatever the limitations these values have, they were the ones that were most readily available on the CT machine, on the console display, and available and acceptable at the time this legislation was put into effect. This legislation actually has a clause that I'm very happy with, because it allows for another unit of dose if it's recommended by the AAPM, the physicists in medicine. And some of the specific limitations of this section cover that the dose recording is not required for radiation therapy treatment, radiation therapy planning, or for CT's use for calculating attenuation coefficients for nuclear medicine studies. Next slide, please. Then the second section of this law is 115112, and that does become effective this July, July 1st. This requires accreditation for CT systems, either approved for, by an accrediting organization approved by CMS, or by the California Medical Board, or by the Department of Public Health. So who are these bodies that are going to be accrediting the CTs in all of the California facilities? We have American College of Radiology, and that's the first one. Joint Commission is the second one, and the Intersocietal Accreditation Commission is the third one. These are the same 3 commissions, or approved organizations, that were approved by CMS under MIPA for outpatient CT care reimbursement. So those were the ones that were initially selected. Next slide. Now, there are some limitations for accreditation requirement that are built into this section as well, and those were specifically listed in here, excluding radiation therapy planning and treatment, nuclear medicine when used for calculating attenuation coefficients, and for CT systems used solely for image guidance for interventional radiological procedures. And with that third one, there is a caveat. If that system is ever used for diagnostic imaging, say it's used as a backup if the main department CT scanner goes down, then that unit must be accredited. That exemption there is only for systems used solely for image guidance for interventional radiological procedures. Next slide. And that then brought us to a quandary in the law, actually. If a facility can't use their CT machine until they're accredited, and they can't get accredited until they use their CT machine, how do we end up with any new growth in CT, any machine replacement, any new facilities? So first we looked at what happens when you add or replace a CT system that is accredited. Add a machine to a place that's already using an accredited CT machine. And they were considered under the umbrella of the current accreditation. So those units can be used while they're in the process of accreditation and be considered under the umbrella of the current accreditation as long as they're in the accreditation process. The second thing we looked at was what about new facilities? And CDPH has determined that a facility can be considered provisionally accredited by CDPH until the accrediting organization renders a final determination, and so may perform CT in the interim if the facility has done three things. The first thing is they have to submit a complete application to one of the approved accrediting organizations. The second thing is they have to receive confirmation of receipt of the application from the accrediting organization, and they have to be proceeding in good faith to complete the accreditation review process in a timely manner consistent with the accreditation body guidelines. So as long as they are actively pursuing accreditation until that accrediting body renders its final decision, we will assume that they are or grant them provisional accreditation. Next slide. Now we'll go to event reporting, and that's section 115113 of the Health and Safety Code, and this section also became effective last July 1st. So event reporting is conditional. It's very conditional. In the first three examples I'll give you, the patient dose must have exceeded specific values, and for A1, the CT examination has been repeated unless otherwise ordered by a physician or radiologist. So an example of that could be that you realize that the contrast wasn't timed correctly, so the study needs to be repeated. If the doctor approves, then it's not a reportable study. If you go ahead and repeat the study without getting doctor approval, it may be a reportable study. Then you'll have to look at whether those dose values have been exceeded. Section A2 requires reporting when CT has been performed without physician approval. We actually did have an event that ended up not exceeding dose values but was reported very early on, so we were aware of it. A new ER doctor said, "No CT, neck is clear." And what the nurse heard was CT, neck to clear, and sent the patient for the study. And when the patient returned, the doctor wondered why the CT had been done since he had not ordered it. Section A3 requires reporting when a CT radiation occurs to a body part that was not intended by the physician or radiologist. I've been told the most common way to have this event is for chest and pelvis to be ordered, but then what actually happens is when they get into the CT room, a chest, abdomen, pelvis is performed because that is such a frequently performed combination that it's just not noticed that the abdomen wasn't ordered initially. Next slide. So the dose values that are the reporting thresholds are 0.05 sieverts or 5 rem effective dose for the whole body, 0.5 sieverts or 50 rem to an organ dose or shallow dose to the skin. And if those numbers look familiar, they should, because they're the same dose values as in NRC Part 35 regulations for nuclear medicine reporting thresholds. Next slide. Okay, Section A4 requires reporting when a therapeutic exposure results in unanticipated permanent functional damage, or CT results in an unanticipated permanent functional damage to an organ, a physiological system, hair loss, or erythema as determined by a qualified physician. Until now, this whole law has focused just on CT, but we do see here that we're looking at therapeutic exposures in this and in further sections down the road. So I did want to specifically point that out, that this law is not exclusive to CT. It's mostly CT, but it's not exclusive to CT. So in this case, the key is unanticipated permanent functional damage here. If the patient has received information concerning risk and potential consequences of the procedure and given consent. So if you've got adequate informed consent that includes your radiologic risk in that informed consent, then the adverse event or the adverse result would not be unanticipated. You've actually already explained that to the patient, and they did agree to the study. Next slide. Section A5 requires reporting when an embryo or fetus receives an exposure that's greater than 50 millisieverts or 5 rem dose equivalent from a CT scan or a therapeutic treatment under the following conditions. There's unknown pregnancy, and the patient's physician did not approve the CT in advance. It's a very tough combination to meet all three of those requirements, but it could happen. If the patient tells the technologist when she's entering the room that she's pregnant right before the study, and the patient's physician did not approve the dose to the fetus, then the only criteria left is whether or not the fetus received a high enough dose to make it a reportable event. So always, if there's any question that the doctor doesn't know the patient's pregnant, send that patient back to the doctor before you do the treatment or the scan. Next slide. Okay, on A6, A6 requires reporting when a therapeutic ionizing radiation occurs to the wrong individual or the wrong treatment site. And that's pretty self-explanatory, wrong person, wrong body part. That is required for any fraction. So if any fraction of a therapeutic treatment is delivered to the wrong person or to the wrong treatment site, you have to report that to CDPH. There are no dose criteria for that. That's a yes or no. A7 requires reporting when the total dose from therapeutic ionizing radiation differs from the prescribed dose by 20% or more. And this is for a final dose. This is not for a fractional dose. So if you have a dose that differs by 20% and it's too little or too much, but you can adjust the protocol, the whole protocol of the entire course of treatment to where the final dose doesn't vary by more than 20%, then you don't have a reportable event. Now there is a palliative care allowance, and we'll go into what those allowances are on that next slide. Okay, section 115113B specifies who and when you're reporting your event. Okay, so for a therapeutic event, you've got 5 days to report it to the department. Those events are pretty clear-cut. They're yes or no for the most part. Now, the department does not need to know if it was a palliative care event. The referring physician does need to know, but you don't have to report that to the department. All the other events, you have 5 days to report them. For CT events, you have 10 days. Excuse me. And you'll report that to the department and to the referring physician, and 15 days to let the patient know. That patient notification has to be in writing, and it's not required for palliative care. So if it's a palliative care event that was the wrong site, the wrong dose, only the referring physician needs to know, and they can make the decision as to whether the patient will be informed. Now, when you report to the department, it's not specified in law whether that report has to be by email, by phone, on a certain form. So we'll go into what's required for that a little bit later on. Next slide. When we go out now for CT inspections, we'll be asking some pretty specific questions related to CT service that we were not asking before. And the first couple of things we'll want to know is the facility CT system accredited, and by whom? Are there appropriate policies and procedures in place? Who determines what protocols are used? Has everyone been trained? Did the physicist identify any issues on the last survey? Next slide. And have there been any events? And then we'll observe what's going on and interview the staff, see what's available at the console, and how the staff's been trained. What we want to have reported to RHB is what your facility has as far as the equipment involved, the operator's name, the physician's name. We'll want the patient information, your facility information, the date of the event, the person making the report of the event, all of their specific information. And then we also want a copy of the doctor's order or treatment plan, an explanation of what happened, and patient dose calculations, including the methodology. And those are only the calculations that made it a qualified event. Those only calculate the patient exposure from CT scans that were not necessary for the diagnosis. If it's the repeat study, the first study, you missed the run of the contrast. Second study was perfect. So the first one was the unnecessary study. You wouldn't use both studies. Okay, so we'll also want copies of any internal investigation reports, including the cause and corrective action designed to prevent a recurrence, and copies of the letter sent to the patient and to the referring physician. And then we'll come out and do an on-site investigation. We'll want to walk through the event, actually going to the location of the event, and have the technologist who was involved in the event review what happened with us. We'll collect copies of images and any documentation that may not have been submitted earlier. And then what we really want to understand how the corrective action is likely to prevent similar events in the future. We would rather have a lot of preventatives and no reportable events. That would be our patient safety goal. Next slide. So what is the violation? There are no dose limits in law or regulation. Failure to record the dose, failure to report the dose, failure to evaluate the displayed dose, and failure to obtain or maintain accreditation. And then in regulation, the section that we have had all along is in Title 17, Section 30305, under general provisions for using x-rays in medicine, the user must be adequately instructed in safe operating procedures and confident in the safe use of the equipment. Next slide. I wanted to leave you with some useful references. We have our website, and we have some frequently asked questions on there. We do have that list of what we want you to report in those frequently asked questions. If there is any question on current legislation, you can get that from senate.ca.gov, and that's current or proposed legislation and to the current law. You can go to aapm.org for CT protocols. You can go to acr.org for appropriateness criteria. Practice guidelines, CT dose index registry, and forms and procedures. jointcommission.org for the CT elements of performance and information on Sentinel event alert and issue 47, and also to intersocietal.org for their accreditation information. Next slide. I'm sure you all have some questions, and we'll get to those in the question and answer section. Thank you.